me then, how are you getting on at the moment with your dry eyes?
Yes, they're pretty good at the moment with treatment I've been doing.
Yeah, and what treatment have you been doing? What have you been...
I put the hot pad on
Yeah.
twice a day, 10 minutes each time. And then I'll treat it with either the little tissues or I'll put the gel, Blephaclean or the Blephar gel.
Yeah.
Yeah.
Fine. And do you do that? Are you able to do it most days?
Yes.
Very compliant patient. And do you find that that keeps your symptoms in check?
Oh, definitely, yes. Yes, it's much better than it used to be.
Okay. So if you would rate your dry eye now, so 0 being normal, wonderful eyes and 10 being as bad as they ever got, where would you rate them?
Must be about between 1 and 2, I should think.
Okay, brilliant,
Yeah.
brilliant. And does it ever flare up? Do you find...
Occasionally. Normally, if I've been out a lot in a cold weather with a wind, I'll notice sometimes they will still go a bit red.
Yeah.
And they do still water quite often, especially if it's cold.
Yeah.
But they're not gritty or feel sore or anything like they used to.
Great. Okay. So just based on that history, I'd be thinking, okay, so our current management is probably doing what we need it to do because she's not that symptomatic. It's maybe only flaring up in extremes of environment, windy, etc. So that's kind of what's in my head at the moment. So let's have a little look, and we can find out what's going on. So, good job, we're both short. Chin on there for me. Okay, so as I was saying, all I'm going to do initially is my sort of general view, okay? So, hopefully... There we go. Okay, so... we probably just want to... I can turn that down a bit, actually. Okay, so, sorry you've got to kind of look in two places at once, but, brilliant. So what you can hopefully see is we've got, I can get the focus. So there's some telangiectasic vessels, so you've got the red vessels there on the surface. She's still got, and I have to admit, I did ask my mum, who very kindly agreed not to do lid hygiene for a couple of days, just to hopefully give you something to look at, really. But you can hopefully see there that there's just a bit of build-up, a bit of kind of grease and crust and debris adherent to her lashes. Look down for me, Mum. So just going to increase the light on there a little bit. Okay, so if we just have a little look, hopefully I'm not bleaching it out too much for you. So looking at the lash root there, you can see there's a little bit of debris, okay, and minimal inflammation. There's really no sort of lid redness to speak of, but we've definitely got just a little bit of debris clinging to the roots of the lashes there, okay. So what I'm going to do, so what I tend to do in practice is obviously when I'm doing a follow-up, personally, I don't need to really check for lid wiper, check for lip cough, do all that, because I know that she's got dry eye. I know what we're doing about it, and then, you know, so I mean, whether that's my non-academic, hands-on practical approach, I don't know, but I'm not overly worried about measuring those things every time I see a dry eye patient. If I'm interested or if they're suffering, then yes, I want to know what those answers are. But if it's a follow-up where they're doing fine, then I'm less, you know, bothered by that data. Okay, I only want to measure something if it's relevant to what I'm going to do. Okay, so if we can find a bit to look at. So I'm just finding a collarette that looks fairly juicy. And what I'm going to do, I'll just increase the brightness a little bit. So I've got just some fine, what we call jeweler's forceps, okay, just fine forceps that you can get. And I'm just going to have a little pick at one of these crusts, okay. So keep looking down, Mum, for me. So is that fairly in focus? Yeah. So literally just using the forceps to pull off the crust, okay? And then what you're doing is looking at the root of that crust and at the moment, I can see Demodex. The resolution on there, annoyingly, doesn't necessarily mean you can see it, but let me see if I can look all the way down, Mum. Do another one. So I don't know if you can make it out. This lash here, there's Demodex at the root. If any of you are particularly keen to see one, come see me after and you can look through the slit lamp. But it annoyingly is just not quite clear enough on the video imaging. But that's basically what you've got to do when you're looking at blepharitis. You've got to pull the collarettes off, okay? So what I want to do next is have a look at what her glands are doing. Yeah.
Where are you seeing?
So,
Is that on the bit you pull off, or is that
no, so not on the bit you pull off, but on the actual root of the bit you leave behind, if you like. So where the end of the lash meets the lid, that's the bit that you want to look at, okay? So literally when you've pulled it off, where you saw the Demodex tail sticking out on that image earlier, is basically the bit that you're looking at, okay? So what I'm going to do is just have a little look at the glands now, because I do want to know what kind of state they're in. So what I use to help me do that is a device that you saw on the video, the forceps, okay? So it's like a meibomian gland forceps, like a paddle, and all it's letting me do is apply pressure either side of the lid so I can squeeze on the surface of the lid without having to press too hard on the eye, okay? So what I'll do is pop a bit of anaesthetic in. Look up at the ceiling, Mum, for me. Look up. Okay. Tissue if you need it. Okay. Right, so chin back on and look up at the ceiling for me. All right, so so you can see the surface there and the glands. So what I'm going to do is literally just get the paddles, okay, and put them either side of the lid edge, okay? So I usually then look through the slit lamp to do this, and just literally squeeze. And it's a bit painful. And there we've got, just turn it down a little bit. A live gland oozing its way out. Okay, so that gland there that we've just squeezed is definitely a grade 4, okay? So that's still really thick, really toothpastey, and also very sort of opaque in colour, okay? So what I then normally do is work my way all the way along, limitations of the video, all the way along just squeezing. And that one there, that's just squeezed out, so I'd probably rate that at a 3. Can you see how it is more runny? It's not oozing out like toothpaste, but it's still quite thick and it's still quite yellowy and opaque, okay? And you do tend to find you get that. So when you have gland dysfunction, you'll get a variety where some will be really bad and others will look not too bad, especially when they're starting to treat them. Okay, and there's another juicy one there, just starting to ooze out. Okay, so when in practice, I would literally go all the way along, squeezing the bottom lid and squeezing the top lid, okay? Because I really do think that is really helping to purge out the contents of those glands, okay? So not only is it a diagnostic thing, but also it's a way of helping that individual just to give them a clean slate again, okay? So in terms of management, what I tend to do is you're doing eye bagging twice a day at the moment. So what we haven't tried yet is Omega. So what I'd probably do is, because I still don't really like the quality of that Mybum, it's still quite thick. There's a lot of studies now that are airing towards use of 2,000 milligrams of fairly pure omega-3 a day. So I think that would be the best thing to do. So I'm not going to even touch lubrication because she's not symptomatic enough to be incentivized to do it. Lubricants aren't going to treat the root cause particularly in her case, so it's really just about trying to improve the quality of that Mybum. So I think carry on with your eye bag twice a day, carry on cleaning. Now you haven't done it for a couple of days, you've definitely got quite a bit of crust appearing again there. Because there is the odd 1 or 2 Demodex, I'm not overly worried about tea tree at this point. If they get much more obvious, I'd probably do an in-office tea tree procedure with her. Would you like to see me do that? Yes? Okay, fine. So, simple stuff in practice. Contact lens case. Tea tree oil. 5 drops or thereabouts. Macadamia nut oil, because it was used in the studies. You're not allergic to nuts, are you, mother? 5 drops of that. Cotton bud. Mix it together. Okay? And then basically, with your saturated tip, you're then going to apply the tea tree mixture onto the eyelids. Okay? Tissue. So, warn the patient, even with the anaesthetic, it's going to feel burny, kind of hot, cold. It's quite an odd sensation. It will sort of sting a bit for a couple of minutes, okay? You might want to keep your lids closed after I've done it for a couple of minutes if you feel the need, okay? So, chin back on. I'll do the other eye for argument's sake. Okay, I'll just keep it on really low mag for this bit. Okay, so look up at the ceiling for me. So all I'm doing is basically, actually I'll do it on this side so it's more easy to see. All I'm doing is using the cotton bud, okay, and we're literally just going to wipe along the lid edge. Okay, and because you've got a dry tip the other end, if you think, oh my gosh, I've got a bit too much oil there, switch your tip over and just mop it up with the other end. So always keep your other tip dry so you can do that if you need to, okay? Right, close your eye and look down, okay? But keep it closed, that's it. And then literally, same sort of idea. So I'll just go slightly higher mag for you. Okay, so keep looking down, and then just literally lifting up the lid a bit and working the oil into the top. Okay, and that is it. That's all you need to do, okay? So the patient can just sit and rest. Is it quite stingy?
Not stingy, but feels a bit hot.
Not stingy but hot was her answer. So most patients are fairly tolerant of it. Some that are fairly sensitive anyway will feel it and be quite sensitized. But always warn them, and then it's usually not too bad. Yeah, it does smell nice. but basically, it's nothing more complex than that, and that is how you then moderate the amount of Demodex that are on a lid. So I will do that whenever I see them that they're getting slightly out of hand again. So if they're treating themselves anyway, but if it's there's quite a few of them, and I just want to nip them in the bud again, because you'll always find that Demodex patients, they'll always get them back again if you don't keep it in check. Brilliant. How long have we got? 15 minutes. Okay, brilliant. What we'll do, if I can have my next patient. How familiar are you guys with Lissamine green use? How many of you use that regularly in practice? Only a handful. Would you like to see Lissamine green? Yeah? Okay. Right, so what kind of issues do you have?
I've just got MGD and quite severe dry eye. I have MGD and quite severe dry eye, so I'm quite symptomatic with it as well.
Okay, she's an optometry student, which is why she knows a bit about herself. Okay, fine. So pop your chin on there. Okay, so let's just have a look. Do you treat your eyes at the moment?
I'm on doxycycline at the moment, but I don't know if it's...
Okay, she's on doxycycline at the moment, so let's have a look. Right then, so general look, white light view. So immediately look down for me. What I can see, there's no crusts, okay? There's absolutely no blepharitis there whatsoever, okay? That much is very, very clear, so that's good. So if you look all the way up at the ceiling, so just generally looking at conjunctival hyperemia, you can see, hopefully you can see lipids in the tears. So you want to just look at how well the lipids are mixing in the tear film. Blink for me. So you can just about see the upwards movement of the lipids as she's blinking. Just about making that out on the video. Okay, look down for me. So just sort of partially averting the lid to have a look at the top lid and the actual glands. You can see immediately, just there, we've got, hopefully you can see, a blocked gland. Okay, so what that tells me is that she's got a keratinized layer, so her epithelium is growing over her meibomium orifices, so she's making meibum and then it's got nowhere to go, so that's why you're getting these kind of capped glands where they're literally got keratinization over the top. So what we want to do is get rid of that if we can. One way of doing that is what we call a golf club spud. You can use these quite effectively. The tip, I'll show you on the slit lamp, the tip itself literally looks like a golf club. Okay, so there you go. Okay, so that's it. And literally, it's like a gentle scraper, if you like. So you're just able to use it to scrape along the lid margin to remove any keratinized issues, okay? So let's see if we can do that for you. Keep looking down for me. Okay, so we'll find that gland. Now, can you see? Okay, so you've got a fairly good view of it there. So basically, I'm just going to use the spud. To drain it. Okay, I don't know how well you saw that. But you can see the actual meibum is now on the spud, and then the block gland is drained, okay? When you see them, you really do want to get rid of them because they become a source of irritation for the patient, literally a bit like a foreign body on the lid edge, and B, because it's keratinized, it's not going to budge easily, so you really do want to kind of pop them and try and clear off the surface if you can. In terms of other features, so general hyperemia is not too bad. I noticed just looking at her, you start to kind of become aware of blinks. And what she's tending to do, and she won't do it now because we're telling her about it, but she's partially blinking, okay? And a lot of people that tend to get drier eyes will have imperfect blinks, and blinking and meibomian gland dysfunction are fairly closely correlated because it's thought that blinking itself pulls the meibum out the glands. So if your lids aren't closing properly together, you're not giving the negative pressure of that blink to suck the meibum out. So if you do have poor blinks, it's thought to encourage a dysfunction of the glands as well, okay? But you've got to try and do that when they don't realise that's what you're looking at, okay? So if we pop some lissamine green in, so in practice, I always put lissamine green and fluorescein in at the same time, okay? And like I said earlier, I think as long as you're consistent, it doesn't matter exactly how you do it, as long as you do it the same way each time. So we've got some saline here. Or does it need to be snipped? So just wetting the florets, and then basically what I do is put look up for me, a small amount of fluorescein in, like that. And then a lot of lissamine green in, like that, okay? So you literally flood the eye with lissamine green. You need a lot of it in order to assess it properly. You have a good few blinks and wipe if you need to. So their eyes should look really quite brightly green, and then you've got enough in. If it doesn't look obviously green, you've just not put enough in the first place. So with lissamine green, it takes a couple of minutes for it to work. So what I then do is my fluorescein assessment, if I can. So it's not great on the video, but anyway, I'm sure you can all do tear breakup time. So imagine that we're doing that. And then looking also, I tend to use that to just have another look at the prism height if it's been hard to judge otherwise, but generally just tear breakup is the main thing, and obviously staining if there's anything obvious there, but I really can't see. There's a tiny bit inferiorly. You might just make that out right at the bottom of the cornea, and again, classic location for poor blinkers. You get that typical band at the bottom of the cornea, okay? So once we're happy that we've done all we need to with fluorescein, we go back to white light, okay? And I'll just turn it down a bit now. So with lissamine green, you can use a Raton filter to enhance it, but you don't need to, okay? You can just use the normal slit lamp light. So if I try and optimize it for you, look up for me. So you get a lid wiper top and bottom, okay? Just about see the lid wiper on the margin. Sorry about there you go. So that's a normal lid wiper. That's meant to be there, okay? That's called a Mark's line, and that just marks the junction between epithelialization and non-epithelialization, mucous membrane. So that's what you want to see and you expect to see, okay? She's also got a little bit of goblet cell damage. Can you see, for example, where it's staining there, the little green flecks that you're seeing are signs of damaged goblet cells, basically. So that's what you use lissamine green to look at, both the goblet cells in the conjunctiva and the lid wiper. Okay, so you can just see that in the center of the video there. So look down for me. So to do an upper lid wiper, I'm going to invert your eye, okay? So keep looking down. Okay. So just have a little look. Okay, so again, that is a normal Mark's line, okay, so that's not a lid wiper. She doesn't really have any epitheliopathy there. If she did, well, there's maybe a tiny bit in that corner. No, I think it's just pooling actually. Yeah, so basically she's not got any lid dry hyperepitheliopathy, but you'd see it behind that line. So further down compared to Marx's line, you'd get a broader, more irregular band of green staining in that zone, you know, once you've averted, and that is epitheliopathy, okay? So if you see that, then you know what's happening when you're blinking is that you've got friction rubbing on the lid wiper is the bit of the lid that's in touch with the eye when you blink. So when you've got your tears are poor, you're not getting enough lubrication, you get a friction burn, basically, frictional damage on that underside of the lid, and that's what is creating the damage to the cells on the membrane. So that's how you do lissamine green evaluation. And I think we might be just about out of time.